Hi folks, this is Alan Heckman, Assistant Professor with the Physician Assistant Program at DeSales University. Today we're going to be talking about the basic metabolic profile and a couple of other ancillary tests. A BMP, or basic metabolic profile, typically includes a sodium, chloride, potassium, CO2, BUN, creatinine, and a glucose. Other items such as magnesium and phosphorus are usually ordered at the same time when you're checking a BMP, but they do not come as part of a BMP. In fact, they don't even come as part of a complete metabolic profile, and so these items typically need to be ordered separately. As you can see at the bottom of the screen here, this is what is the medical shorthand for when you're documenting the results of a BMP. This you might find as you're documenting in an H&P or in a SOAP note. Just for clarification here, the purpose of this presentation today, we're going to cover sodium, potassium, the BUN, creatinine, and glucose. Chloride and CO2 will be covered later when we do the arterial blood gas lecture. Sodium is the primary extracellular electrolyte. It's very important in our physiology. It helps to maintain proper extracellular concentration of water and electrolytes. It attracts water to help maintain fluid balance. It helps transmit nerve impulses with regards to action potentials and depolarization. And it helps to maintain the acid-base balance by combining with chloride and bicarb. When we're talking about the regulation of sodium in our body, there are really three key players to help keep this in check. The first is antidiuretic hormone, then there's aldosterone, and the sodium-potassium pump. Let's first talk about antidiuretic hormone. When your body is slightly dehydrated because of a lack of free water, your sodium levels are higher in concentration. This stimulates your thirst center, and you know that you want to go and get something to drink. This little bit of dehydration and increased sodium levels stimulates the posterior pituitary gland to release antidiuretic hormone. This causes the kidneys to retain sodium and as a result reabsorb water. An important concept here to remember is water will always follow salt. I can't stress that enough. Water always follows salt. When this water is reabsorbed, it dilutes the blood and it helps to normalize the serum osmolality. Thus, the sodium levels return to normal, and this feedback loop goes back to the pituitary gland, and at that point, it stops producing antidiuretic hormone. The next regulator of sodium is aldosterone. Aldosterone is a hormone secreted by the adrenal cortex. You may remember this has to do with the renin-angiotensin system. As angiotensin 1 is converted to angiotensin 2, this helps stimulate the release of aldosterone. Aldosterone works directly on the kidneys to reabsorb salt, and as stated earlier, water follows salt. So this helps to regulate the overall osmolarity and sodium levels within the blood. The third mechanism is the sodium-potassium pump. You may recall this from your undergraduate physiology courses. Both sodium and potassium are positively charged ions. Your body requires this pump to keep these ions in balance across the cellular membrane. Normally, there's little sodium inside the cell and lots of potassium inside the cell. This makes the cell happy by keeping these two electrolytes in balance across the cellular membrane. Now, if you recall from your undergraduate science classes, you'll remember that diffusion is the movement of a substance with higher concentration and it moves to an area of lower concentration. Since there's a significant amount of sodium on the outside of the cell, it wants to move inside the cell to regulate its balance. The same holds true with potassium wanting to leave the cell. This would not be good for the cellular membrane. We need to keep these two ions where they belong for that membrane potential there to the cellular membrane. The sodium-potassium pump actively keeps sodium from building up inside the cell by actively pumping sodium out of the cell and potassium into the cell to keep these two concentration gradients always at the same level. Okay, so let's dive right in. There's hyponatremia and hypernatremia. To the common person, this would appear like this is a salt problem. but in reality it has nothing to do with the salt itself. This is a water problem. You either have too much free water on board or you don't have enough on board. Okay? If you have too much water, then you are hyponatremic. Too much water makes the salt level or the sodium level drop. Too little water makes the sodium level appear high, giving you hypernatremia. Please refer to the clinical, this would be not medicine, but let's cross that out, clinical reasoning packet called My Husband is Acting Strange for the full notes on hyponatremia. Remember that hyponatremia is a sodium less than 135. Hypernatremia, this is going to be a sodium level greater than 145. But we all know in reality this has to do with water. There's not enough water. You're dehydrated. The most common cause of hypernatremia is dehydration. It's actually less common than hyponatremia, and our major defense mechanism against this in our body is thirst. We're thirsty, we want to drink to bring more free water on to regulate that sodium level. Things to consider clinically here are people who cannot access water, like infants, confused adults, the unconscious, or immobile patients. If these are any of your patients, then you need to consider the fact that they could be dehydrated because they didn't have access to free water. Other patients that you need to be concerned about with hypernatremia would be patients with like diabetes insipidus. Now these folks can urinate up to 4 gallons per day. So if they're not drinking enough to keep up with that demand, they will surely get hypernatremic. In addition, people who are getting tube feedings, you need to watch for hypernatremia as well. These folks are getting a nutrition because they're unable to swallow for whatever reason, and they're getting lipids and proteins and carbohydrates through this tube feeding, but you got to remember they need water as well, just like we do. So if water is not being added to the tube feedings, they too can become dehydrated and get hypernatremic. All right, we're moving on to potassium now. As you can see at the top of your screen, the normal level or range for the potassium is 3.5 to 5.0, depending on which lab you're working with. This is the primary intracellular electrolyte. Only about 2% of potassium is found outside the cell. It's considered to be the primary buffer inside the cell, and it's going to work directly with hydrogen ions. We're going to talk a little bit about that in a few minutes. Potassium is primarily excreted in the urine, and important to know is that when cells are damaged, they're going to release potassium into the blood. So one of the big things to be concerned about here is you'll get a reading back that'll say the potassium is elevated. The first thing you always want to do is check to see if the sample was hemolyzed, meaning that when the cells came through the needle, when the blood draw was obtained, some of those cells can rupture, and as a result, the potassium is released into the serum, and so when they run the test, it comes back that the patient is hyperkalemic. You just have to check to see if it went through this process where it was hemolyzed, and if that's the case, you just repeat the lab. All right? Other things to remember about potassium is that it helps to regulate the cellular membrane concentration, like we were talking about earlier, and it's really important in things like skeletal and cardiac contractions. Now, there are two main mechanisms for the regulation of potassium in our bodies. The first is insulin. As we take in K as a part of our diet, it rapidly enters the portal circulation, and this stimulates the pancreas to release insulin. Elevated insulin induces rapid transport of potassium into the cells. This is through a process called facilitated diffusion. As insulin activates the cells to allow glucose to go in, potassium more or less rides on the coattails of glucose and sneaks into the cell that way. The other major mechanism here is renin. Increased potassium in the serum causes the kidneys to release renin. This stimulates the hepatic activation of angiotensin 1 to angiotensin 2, just like we were talking about before with sodium. Angiotensin 2 stimulates the adrenals to secrete aldosterone. Now with sodium, aldosterone causes the kidneys to reabsorb it. But in this case, aldosterone tells potassium that you're not needed anymore, and it's excreted in the urine. Potassium plays a role in our acid-base balance. Hydrogen ions and potassium ions, they freely exchange across the cellular membrane. When there's acidosis, all right, in other words, too much hydrogen ions in the serum, hydrogen ions will move from higher concentration in the serum to lower concentration inside the cells. When this happens, it pushes potassium out of the cell. Therefore, people with metabolic acidosis end up getting a hyperkalemia. In contrast to this, when there is alkalosis, your body tries to regulate this, and it will take whatever hydrogen ions are inside the cell and cause them to leave to go into potassium plays a role in our acid-base balance. Hydrogen ions and potassium ions freely exchange across the cellular membrane. When there's acidosis, in other words, too much hydrogen ions in the serum, the hydrogen ions will move from a higher concentration, aka the serum, to a lower concentration inside the cell. When these hydrogen ions cross the cellular membrane and move into the cell, it forces potassium out of the cell. Therefore, people with metabolic acidosis will have a hyperkalemia. In contrast to this, when there's alkalosis, potassium moves into the cell and tries to create that balance. Therefore, people with a metabolic alkalosis, they can have a hypokalemia. All right, so let's talk about hyperkalemia. All right, this is going to be a potassium greater than 5. The workup for this, or things to consider, is going to be done in a stepwise process. So step 1, we're trying to exclude erroneous reasons for the potassium to be elevated. So one of the things to consider would be a lab error. Nowadays, many labs are done by a machine, and so sometimes if the machine's not calibrated correctly, it can give you a false reading. Traumatic venipuncture, like I mentioned earlier, as those cells go through the needle, some of those cells can rupture and as a result release potassium into the serum. Pseudo-hyperkalemia, there's a bunch of different reasons for this. Hemolysis, as cells are dying off and break down, they can release potassium into the extracellular space. A clotted specimen, potassium moves out of platelets, and that can alter the specimen as well. And leukocytosis for reasons that we're not sure. So now, how do you know if this is truly just an error or a false reading versus someone who's really sick? Well, look at your patient. These patients are going to be asymptomatic, and they're probably not going to have any EKG changes. So in a patient that you have absolutely no reason to explain hyperkalemia in, who looks fine and has no EKG changes, but suddenly you get a lab back that shows they have a potassium greater than 5, you probably should consider repeating the test before you do any interventions first. Step 2 in the workup of hyperkalemia, look at their meds. A common cause of hyperkalemia is the start of a new medication, and the offenders of this typically are ACE inhibitors, ARBs, NSAIDs, and potassium-sparing diuretics. Step 3, what's their kidney function like? The excretion of potassium is completely dependent on having enough aldosterone and having functional kidneys. So if you've ruled out drugs as the cause, and you've ruled out a bad lab test, then you got to look at their kidney function here. So consider things like renal failure and renal hyperperfusion. Also consider hypoaldosteronism as a potential cause for the hyperkalemia. Step 4, let's look at other diagnoses that are causing this, such as a rapid increase in potassium released from the cells. You can see this in people with burns. As those cells are being destroyed, it's releasing potassium into the serum. Conditions like rhabdomyolysis, as a muscle tissue is being broken down, it too is going to release potassium. Metabolic acidosis, we just mentioned that earlier. Adrenal insufficiency. Now you're going to typically have hyponatremia with this as well, but the whole reason behind this is that they're not releasing aldosterone. So remember, aldosterone is going to save salt, and it's going to tell you to get rid of the potassium. Another diagnosis to consider would be uncontrolled diabetes, which we're going to talk more about on the next slide. Patients with uncontrolled diabetes may lead to problems with hyperkalemia down the road. As you recall, insulin normally promotes the movement of potassium into the cells. However, when you have a combination of insulin deficiency and increased osmolality secondary to all of that sugar sitting in the serum, well then water is going to need to shift from inside the cells to outside of the cells to regulate that balance. And when water leaves the cells, potassium is going to go with it. this is going to result in a hyperkalemia. Now look at the bottom of the screen here. Typical labs that you're going to follow as you're treating a patient with hyperkalemia is going to be a serum potassium, a BUN and creatinine, because that's going to help us determine the kidney function. Sometimes people will talk about measuring urine excretion of potassium. However, in patients with chronic hyperkalemia, this is absolutely of no value. So let's talk now about the workup for hypokalemia. This is going to be a potassium less than 3.5. And you'll see over there on the right, I put a range there for you to take a look at. The mild, moderate, and panic value. A panic value is also going to probably be known as a critical lab value. If you were ordering these as outpatient labs, this is going to prompt your lab to call you directly to let you know that there is a critical, potentially life-threatening value here to this lab and that intervention needs to take place. All right, so let's look at this workup. Step 1, look at the medications. The most common medications notorious for causing hypokalemia are going to be your diuretics, specifically your loop diuretics like Lasix and your thiazide diuretics. Incidentally, you'll know that most patients that are on chronic Lasix therapy typically are on a potassium supplementation. Step 2, consider increased loss of potassium. This can either be through renal loss, which you can look at the renal function to see how that is, but another thing to consider here is going to be GI loss. Now, in an upper GI loss, such as with active GI suctioning, like with an NG tube, or with vomiting, you can lose some potassium through these secretions. Typically, those secretions, though, have very low amounts of potassium. But consider this. If you are losing a lot of volume because of vomiting, you're going to get hypovolemic and or dehydrated, which is going to cause an increased release of aldosterone, which, as we've learned thus far, will cause your kidneys to dump out more potassium. This is what's going to result in the hypokalemia then. Now, lower GI loss, such as with diarrhea or like laxative abuse, this actually will produce a hypokalemia because the lower GI secretions have a very high potassium content, and this is typically the primary mechanism for hypokalemia. So a common scenario here is going to be a patient presenting to the office, ER, urgent care, who has had a couple days worth of diarrhea, and when you go ahead and look at their labs, they're going to have a low potassium. Step 3, consider decreased intake. Now, with our American diet, we typically don't have to worry about this, and your kidneys are really good at conserving potassium when it's needed. So this is rarely seen, but it is something to consider. Step 4, other things to consider, like if the patient recently got insulin and glucose, well, as we've learned earlier, that's going to drive potassium back into the cell, and so your serum potassium levels will decrease because the potassium left the serum and went into the cells in patients who recently just got insulin and glucose administration. Other things to consider would be like metabolic or respiratory alkalosis, as we learned earlier as well too. All right, so let's look at this from a clinical workup. You have a patient who's got hypokalemia. What should you do? Well, for the most part, you're going to be able to determine the cause by the history itself. If a patient complains of several days' worth of diarrhea, or they've recently been started on Lasix and they didn't add a potassium supplement. So if you can determine the cause there, great, you're fine. But if you can't, then there's two things that you need to do. You need to assess the urinary potassium excretion, and you also need to assess the acid-base status. All right, so let's check the urine then. Now, the normal urinary response to hypokalemia is going to be a decreased potassium secretion. Why? Because when you're hypokalemic, this will reduce aldosterone secretion. As a result, you'll have reduced potassium being excreted from the kidneys into the urine. The other factor here is that you're going to get an increased active potassium reabsorption by the potassium hydrogen ion pump. The 24-hour urine collection is the most accurate way to measure urinary potassium excretion. Now, if the 24-hour K is less than 25 to 30 milliequivalents per day, then you can safely say that the kidneys are not the cause here of the hypokalemia. They are not potassium wasting, just getting rid of it. Okay? Rather, this confirms that the kidneys are actually doing what they're supposed to do in this situation, which is reabsorb potassium. This then supports the diagnosis that there's an extra renal cause for the potassium loss, such as vomiting or diarrhea. All right. On the other hand now, if the 24-hour potassium is greater than 30 milliequivalents per day, in other words, we're putting a lot of potassium out into the urine, in a patient who's hypokalemic, then we have to suspect that there's a renal cause, such as diuretic use or like a tubular acidosis. All right, so just to reiterate here, 24-hour urine collection for potassium in a hypokalemic patient. If the amount of potassium is less than 25 to 30 milliequivalents per day, then the kidneys are not the problem. It's something else, such as the vomiting or diarrhea. However, if the 24-hour K is greater than 30 per day, then the problem lies in the kidney. Speaking of the kidney, let's move on now to the kidney functions. So we're going to start here with the blood urea nitrogen, otherwise known as the BUN. Now this is formed in the liver, and it's the final product of protein metabolism. The BUN varies inversely with the GFR. Typically, as the BUN goes up, the GFR goes down, and vice versa. However, this is not a true constant, and actually the BUN is less useful than a serum creatinine because the BUN can change independently of the GFR. Why? Well, the rate of urea production is not constant. It can be increased with a high-protein diet, and it can be enhanced with tissue breakdowns from like hemorrhage or trauma. Or, on the other hand, if you have a low-protein diet or if you have like liver disease, this can lower the BUN without any change in the GFR. So the creatinine is probably the better way to look at it, but we're going to take the creatinine and the BUN together along with the GFR to help us paint a picture of what's going on with the kidneys. The second reason why the BUN is a little less accurate than the creatinine level is because about 50% of the filtered urea is passively reabsorbed in the proximal tubule. So when there's a volume loss, there's a parallel increase in urea reabsorption, causing the BUN to rise out of proportion to GFR increase or creatinine change. This is why the BUN-creatinine ratio is a proposed way of looking for decreased renal perfusion. So to sum that up here, you may see an increased creatinine to BUN ratio in people who are dehydrated. We're going to talk more about that in a little bit. The other element in assessing the kidney function is the creatinine. The creatinine is often used to estimate the GFR, which is the glomerular filtration rate. Remember that creatinine is derived from metabolism of creatine and skeletal muscle, and it's also from dietary intake. It passes freely across the glomerulus and is neither reabsorbed nor metabolized by the kidney. A small amount of creatinine is also secreted by the kidneys. Now, if GFR, creatinine secretion by the renal tubules, creatinine intake, and muscle mass all remain constant, then the plasma creatinine concentration should also remain constant. So a little equation here to remember is that the constant is equal to the glomerular filtration rate times the serum creatinine. Therefore, these two have an inverse relationship. As the creatinine level goes up for whatever reason, the GFR will go down, and vice versa. It's important to note, too, that women here typically have lower levels of average creatinine due to having typically less muscle mass compared to males. Okay, the creatinine clearance. This reflects the volume of plasma that is cleared of creatinine per unit of time. In other words, how much creatinine can we filter out of the plasma over a period of time? The creatinine clearance utilizes a different equation to take into account the secretion of creatinine in the tubules. So in other words, remember, we're talking about now pulling creatinine out of the plasma. We're filtering out in the kidney. However, remember, a part of the kidney also secretes creatinine as well. So this equation takes that into effect. All right? It compares the level of creatinine in the urine with the creatinine level in the blood. It typically requires a 24-hour urine collection for the most accurate results. However, Most people are just going to have this value estimated using the Cockcroft-Gault formula. Now, many labs will do this for you automatically. So when you order a BMP, sometimes they'll automatically give you an estimated creatinine clearance based on the levels that they've gotten from the lab. A creatinine clearance will typically be 10 to 20% higher than a GFR. This is due to the fact that the creatinine secretion is also occurring in the kidneys. Now, you might be asking yourself, what does this matter and why do I need to know this? Well, you're going to use creatinine clearance a lot of times with regards to pharmacology. Remember, a lot of medications are cleared by the kidneys. So if you're treating a patient with chronic kidney disease and you need to give them a specific medication, such as an antibiotic, you're going to learn that there are dose adjustments that need to be made based on a creatinine clearance. So for patients who have chronic kidney disease and who have a decreased ability to clear creatinine, you're going to potentially need to put them on a lower dose of that medication to maintain appropriate therapeutic levels and reduce the potential for toxicity. Okay, the BUN to creatinine ratio. This is important and it's going to help you out in a lot of clinical situations. A normal BUN to creatinine ratio is about 15 to 1. When the ratio approaches 20 to 1 or more, it's suggestive of a problem with blood flow to the kidney. This can typically be because of dehydration or an acute hemorrhage or even a chronic slow hemorrhage like with a slow GI bleed. A BUN to creatinine increase ratio suggests that there's a problem in the pre-renal phase here. So once again, think of it either being blood or fluid. On the flip side, a BUN to creatinine ratio of 10 to 1 suggests that there is an intrinsic problem in the kidney, all right, like glomerulonephritis or an acute tubular necrosis. So when you see a patient with an acute renal failure, look at the BUN to creatinine ratio. This is going to tell you if the problem is coming before the kidney, such as in pre-renal issues like dehydration, or it's a problem within the kidney itself. Moving on to glucose now. Let's just review quickly glucose physiology. Normal glucose homeostasis involves two hormones, glucagon and insulin. All right, insulin will decrease gluconeogenesis. It decreases glycogenolysis. It increases skeletal and adipose uptake of glucose via translocation of glucose transporters from intracellular pool to the cell surface, and it inhibits glucagon. So the net effect of this, you get inhibition of hepatic glucose production and increased utilization of glucose load that isn't taken up by the liver. Glucagon causes an accelerated glycogen breakdown in the liver, aka gluconeogenesis, which results in increased blood sugar levels. Now let's talk about a normal response to low blood sugar in a normal person. When glucose is not available from the intestines, counter-regulation mechanisms take place in a specific order. Number 1, decrease insulin secretion. All right, this occurs within minutes. Number 2, increase glucagon secretion. Glucagon acts only on the liver, so it's going to stimulate gluconeogenesis and the breakdown of glycogen into simple sugars that your body can use. However, you must have a normal functioning liver for this to work. If your liver ain't working, this ain't going to work. Step 3, increased epinephrine. You're going to get a catecholamine release, and this has the same effect on the liver as does the glucagon. Just like in your fight or flight mechanism, when your body's under stress, epinephrine and the sympathetic nervous system are going to shift glucose to the skeletal muscles and break down glycogen so that you have readily available blood glucose levels for your body to burn as energy. This also inhibits insulin secretion. Number 4, cortisol and growth hormone release. This does happen, but only if you've had low blood sugar for several hours. Here's a quick clinical tip here for you. Diabetics, it's not loose insulin. Let's cross that 1-0 out. Diabetics lose insulin and glucagon as regulatory hormones. The end result of this is, in long-standing diabetics, is a constant reliance on epinephrine to protect themselves against hypoglycemia. This is why when you encounter a patient acutely with hypoglycemia, they're sweaty, they're pale, they're tachycardic. Why? Because of the catecholamine release they're getting, because of that increased epinephrine. They're getting a sympathetic response to their hypoglycemia. All right, so let's talk about glucose testing. A fasting blood sugar normally is between 70 and 126 milligrams per deciliter. If your fasting glucose is anywhere from 100 to 125, then we call that an impaired fasting glucose, or some might say that that's pre-diabetes. All right, these people are definitely at risk for developing diabetes. If your fasting glucose is greater than 126, well then congratulations. You've met the diagnostic criteria now for diabetes. Other things to consider in patients with elevated glucose: Cushing syndrome. Why? Because they have increased glucocorticoids, which result in increased blood glucose. Incidentally, patients who are taking steroids for whatever reason, like a recent asthma exacerbation or some type of rheumatological condition, they too will also have increased sugar levels. So when you're treating patients who have a history of diabetes and you need to put them on steroids for a reason, always make sure that you're aware that their blood sugar levels are going to go up as a result of that. Other things to consider: pituitary adenoma. They will release increased growth hormone, which causes increased blood glucose levels, and just physiologic stress, particularly in the hospital, for patients who have increased metabolic demand, such as fighting off a severe infection or they've had recent surgery. I can tell you that in heart surgery, all of our patients, regardless of whether they're diabetic or not, get put on an insulin drip following surgery. Why? Because their body's under so much stress that they have a tremendous amount of gluconeogenesis taking place, which is causing elevated blood sugar levels. Elevated blood sugar levels increases your risk for post-op complications such as infections. So it's always a good idea to keep that in mind when you're dealing with a patient who could be under stress. They're going to have elevated glucose levels. Now, if the fasting glucose is less than 70, then they have hypoglycemia. And the differentials for this should include idiopathic hypoglycemia, an insulinoma, or liver damage, or just somebody who just took too much insulin that day. One of the tests that you can order or obtain when you're screening somebody for diabetes is a glucose tolerance test. Now, in a normal person, a large glucose load is utilized almost immediately. So if you go and you eat a bunch of cake icing, your body's going to use that and burn it up pretty quickly. Glucose levels typically peak in about 30 to 60 minutes, but they should be normal within 3 hours. So in anybody without diabetes, you can eat as much cake icing as you want. In 3 hours, your sugar levels should be back to normal. In this test here, a patient is given a 75-gram dose of glucose, typically dissolved in water. And from what I hear, it doesn't taste that wonderful. Then what they do is they draw a glucose level at 30 minutes, 1 hour, and at 2 hours. It's considered to be an impaired glucose tolerance if the 2-hour value is between 140 and 199. If your glucose level at 2 hours is greater than 200, congratulations, you now have diabetes. If the patient vomits, the test is completely invalid and you got to wait 72 hours before you can repeat the test again. You're going to learn more about this test when we talk about gestational diabetes in your OB/GYN section of ClinMed Pathophysm Pharm this summer. The glycosylated hemoglobin, otherwise known as the hemoglobin A1C, reflects the average blood sugar over a 3-month period. Glycosylation, which is basically the binding of glucose to a protein molecule, occurs slowly and typically takes place within the red blood cell. Within the red blood cell, there's hemoglobin, which is a protein. So you get glycohemoglobin, all right, which is blood glucose bound to the hemoglobin. It's an irreversible attachment to the beta chain of the hemoglobin. And this test is elevated in people with diabetes. Typically, before, we used to do a fasting glucose to help us make the diagnosis of diabetes. But now the standard of care seems to be more this hemoglobin A1C. So generally the cutoff is about 6.5. If you have a hemoglobin A1C greater than 6.5, congratulations, you have diabetes. A hemoglobin A1C, though, can be decreased, but that's typically seen in conditions like hemolytic anemia, chronic blood loss, or recent transfusion. All right, so now let's just talk about the actual diagnosis of diabetes. Most commonly, as we've discussed, we typically look at glucose as a way to screen or diagnose diabetes. The criteria that we're going to talk about here is based on the recommendations from the American Diabetes Association. And we're going to make this diagnosis based on one of 4 diagnostic criteria: the hemoglobin A1C, like I just mentioned, the fasting plasma glucose, a random elevated glucose with symptoms, and an abnormal glucose tolerance test. All right, so here we go. You only need one of these things to make the diagnosis, although typically you probably would have multiple tests here being positive, but you don't need to do that. You just need one of these things. So as I mentioned before, a hemoglobin A1C greater than or equal to 6.5. Congratulations, you have diabetes. A fasting blood sugar, meaning that they've had no caloric intake for 8 hours, equal or greater than 126. Congrats, you have diabetes. A 2-hour plasma glucose greater than or equal to 200 during an oral glucose challenge, that will also give you a positive test for diabetes. And then a patient with classic hyperglycemic symptoms with a random plasma glucose of 200. I typically see this in the emergency room all the time when a patient comes in who hasn't seen a doctor in 10 years, who comes in with dehydration or some other problem, and we do a random glucose on them and their glucose is 400. Now, to actually confirm the diagnosis, okay, you typically need to have 2 tests done. Unless the patient has got some unequivocal symptomatic hyperglycemia, like diabetic ketoacidosis. Well, then, if you don't have that, then you have to technically confirm it on a different day. As I mentioned to you earlier at the beginning of this presentation, most of these labs are now done by machines, and if they're not calibrated correctly, you may not get an accurate test. So, just like with a blood pressure, you're not going to always make the diagnosis of hypertension based on one reading. You're going to repeat it and make the diagnosis. Well, the same really should hold here unless they have like overwhelming symptoms like diabetic ketoacidosis. Otherwise, you need 2 tests. You can either repeat a test of whether that you obtained, or you can just use another test. Like if you happen to get a random glucose and a hemoglobin A1C, and they were both elevated, well then you have the diagnosis. Let's spend a few minutes talking about screening for gestational diabetes. First of all, who are we going to screen? All pregnant women. All pregnant women are going to get screened during their pregnancy. This is typically done between weeks 24 to 28 of gestational age. However, if you feel that your patient has undiagnosed diabetes, then you should be testing them right away. Here's how the screening process works. It's a 2-step approach. First, you're going to administer to a non-fasting patient 50 grams of oral glucose. All right? This is going to be done, and then the glucose is going to be measured 1 hour after ingestion, commonly called a 1-hour GGT, or glucose tolerance test. If the serum glucose is greater than or equal to 130, then a 3-hour oral GGT is given. The 3-hour GGT is performed as described above, except that the glucose load is 100 grams, not 75 grams, and an additional 3-hour glucose is measured. So here it goes. You come in, you're going to get 50 grams of glucose, and in an hour, we're going to check your sugar. If it's greater than 130, then you're going to come back again, and we're going to do a 3-hour glucose test where they give you 100 grams. You're going to wait 3 hours, and then you're going to have it measured. If both of those tests are abnormal, then you have a positive diagnosis for gestational diabetes. We spent time talking about glucose tests. Now we're going to talk about insulin tests. These tests are important to establish diagnoses such as an insulinoma, abnormal carbohydrate or lipid metabolism, or in the workup of unexplained hypoglycemia. Increased levels with these tests might indicate an insulinoma, untreated diabetes, Cushing's syndrome, and even liver disease. Decreased levels, though, are seen sometimes in severe type 1 diabetes and hypopituitarism. Clinical tip here, insulinomas secrete unpredictably high levels of insulin, which can cause a sudden plummet in blood sugar. This is tough for patients because sometimes the blood sugar drops so quickly that they're unable to give themselves any oral glucose or eat something to help keep their levels up. And so they end up becoming comatose before they can self-treat. We talked earlier a little bit about glucagon. Remember that this originates in the alpha cells of the pancreatic islets of Langerhans. This is different than insulin, which develops in the beta cells. And this promotes glucose production in the liver and is normally counterbalanced by insulin. The kidneys, interestingly enough, have an effect on glucagon metabolism. For example, if you have elevated fasting glucagon levels in patients with chronic kidney disease, this resolves after they get a renal transplant. So the kidneys have a huge effect on the regulation of glucagon levels. High glucagon levels in diabetics will typically return to normal after insulin therapy is started. Once you've obtained a glucagon level, you have to interpret it. So low levels are typically seen in patients with pancreatic tissue loss, such as pancreatic cancer, chronic pancreatitis, or even cystic fibrosis. These folks here, they demonstrate a failure of glucagon levels to rise upon the infusion of arginine, and this basically confirms that there's a glucagon deficiency. Patients with high levels of glucagon, they typically are found in diabetes, acute pancreatitis, hepatic cirrhosis, and patients under extreme stress or increased metabolic demand secondary to an infection. All right, folks, we're almost to the end now. We're going to talk about C-Peptide now. C-Peptide is formed in the beta cells of the pancreas, and it's formed during the conversion of proinsulin to insulin. Proinsulin is cleaved, and the end product is C-Peptide and insulin. Mature insulin and inactive C-peptide are stored together in the pancreas and are released together. That's important, okay? So when we see elevated insulin levels in our body that were naturally occurring, insulin that we produced, we should also have an elevated C-peptide to go with that. All right, so this test allows us to distinguish between exogenous and endogenous circulating insulin when working up hypoglycemia. We'll talk about that more in just a second. Take a look at this chart here. As I was just mentioning on the previous slide, when your body produces insulin naturally from the pancreas, it's going to also produce C-peptide. So when your insulin levels are up, the C-peptide will be up, and so on and so forth. Where this is going to become important to you is when you have a patient who may have an unexplained hypoglycemia. And now you have to try and figure out, okay, do they have an insulinoma, or did they take an overdose of their insulin? Or was somebody doing something shady and they injected somebody with insulin? If you're not sure, you can get a C-peptide. If somebody took an inappropriate dose of their synthetic insulin, the C-peptide will be low. However, if they're producing high levels of insulin because they have an insulinoma, then their insulin levels will be high as well as their C-peptide. So this is a great test that you can use to distinguish between the two conditions. All right, folks, that sums up the basic metabolic profile, as well as some extra tests in there to help us diagnose diabetes. I hope you found this informative. Certainly, if you have any questions at all, feel free to reach out to me via email or come by and see me in my office. Thank you so much, and I'll see you guys in class.